All right. Once again, thank you everyone for being here, and I'm glad you were able to join us. I would like to just quickly introduce you to the agenda that we'll be covering today. And I want to make sure that you remember one thing that as we start. Do not hesitate to ask questions. If you would like any clarification or on something during the presentation, if you have any other questions that weren't covered during the presentation, please reach out to us through the patient portal. This will be a review for a lot of you, since you have already met with Dr. Levy and have signed up for treatment. But just in case, let's start off with online consultation, possible test kits shipped to your home, medications prescribed and sent to your home, and then the rest of the process. So again, this is a review, but I wanted to remind you that the most correctable causes of infertility can be explained by four factors. Ovulatory dysfunction accounts for 40%, fallopian tube obstruction for 20%, low ovarian reserve that is age dependent for 10%, and sperm quality for 30%. Undiagnosed infertility is a very vague and nebulous category that often overlaps with the other factors. So how effective is medical treatment for the most common cause of infertility? Oligoovulation or ovulatory dysfunction is corrected with ovulation induction. And the cumulative pregnancy rate with a single agent after 3 months is 60%. After 6 months, it goes up to 75%. So what do you need to know when starting treatment? Time to conception is not a clear-cut timeline. It takes 4 to 5 months on average to get pregnant. Please do not be discouraged if you do not get pregnant after 1 month. As you can see on this infographic, a healthy 30-year-old, meaning a couple with no issues of infertility, has about a 20% chance per month of getting pregnant. As you get older, that chance dips to 5% per month, per cycle, per try. Now, why is that? So this is probably a familiar graphic to you. It covers the menstrual cycle, and in reality, your menstrual cycle is actually 2, even 3 separate processes. You have the ovarian cycle, where the follicle is recruited, it grows and develops a mature egg inside, ovulation occurs, and corpus luteum then supports the uterine lining. You also have your endometrial cycle, where the uterine lining sloughed off right at the beginning of the cycle, that's your menstrual bleeding, and then slowly builds up, changing in quality so that it can support the implantation and the growth of the embryo. This is all connected to and driven by your hormone function. So the follicle-stimulating hormone, of course, goes up as the egg develops and dips down afterwards since it's no longer needed. Luteinizing hormone is the one that finishes the maturation of the egg and allows it to ovulate. So as you can see, it stays relatively steady and jumps up sharply. That's your LH peak or surge just before ovulation occurs. In addition, your estrogen and progesterone levels are going to go up with ovulation, and those in combination, they will be supporting the uterine lining and make it ready for implantation. Another part of the cycle is the development of cervical mucus. Cervical mucus is produced by the cells in the cervix. And what they do is they change from this kind of white, clumpy consistency to the egg white consistency of clear and springy. This basically allows the sperm to swim easier through the cervix and the vagina and make it into the uterus. In an analogy would be if you're trying to swim across the pool, it's a lot easier to swim through clear water than maybe something of a jello consistency. Now, why does it take up to 6 months to get pregnant? Why does it take on average 4 to 5 months? Well, because you have this menstrual cycle that goes approximately 28 days from the start of another one. But it has this itty bitty narrow opportunity of just a few days per month when you have the higher likelihood to conceive. Everything has to line up. The cervical mucus has to be appropriate consistency to help the sperm swim through. Uterine lining has to be a certain quality to and kind of stickiness to accept and hold on to the embryo. Ovulation has to occur. The hormone levels, the progesterone, estrogen, and LH have to surge in order to prepare the egg and the uterine lining. So when you have only about 3 to 4 days per month, I would say even more like 2 to 3 days per month, when is your best fertile window, you can see that chances of getting pregnant after just one cycle are not very high. Another part that contributes to that lower chances is your anatomy. When the sperm enters the uterus, it can swim one way or the other. Now, what happens if the egg and the sperm meet in the fallopian tube? That could lead to conception. But what if the egg releases on the right and the sperm flow to the left? As you can see, we cannot control the direction of the sperm flow. And if there is no sperm waiting for the egg when it makes it to fallopian tube, about 24 hours after ovulation, when this egg makes it into the fallopian tube, and maybe another 12 to 24 hours later, if there's no conception, the egg starts to disintegrate. The reason I went into detail on that is, again, just to remind you that it is not it does not mean that you have no chance of getting pregnant or that you have low chances of getting pregnant. Our own anatomy and physiology can work against us a little bit, even under the best of circumstances. Now, what can we do to maximize the chances for conception? One is to identify your fertile window. The proof test, that we send allows you to do a couple of things. The LH testing can monitor the LH levels and note when that peak occurs, so that you know when your most fertile window starts. In addition, after ovulation, a few days later, you can do the proof PDG test to confirm that ovulation had indeed occurred. PDG, progesterone is the hormone released after you ovulate and is necessary to prepare the uterus for implantation. And PDG is a metabolite product, so it reflects the levels of the progesterone that you yourself produce. This is not going to reflect how well you're being supplemented with additional progesterone. So the PDG levels do not reflect how much progesterone there's actually inside the uterine lining working to support the embryo implantation. We also use some what we call STEP protocol, and that is that we try you on for 3 months on one medication, either letrozole or Clomid, and if you're not successful, switch to a different medication or a combination protocol. The letrozole is usually the first choice of treatment for patients with ovulatory disorders based on current studies and recommendations. And another thing that we can add is the trigger shot or human chorionic gonadotropin. The brand name that we use is Ovidrel, and it is a treatment option available to you. It is a one-time self-administered prefilled syringe. It's a subcutaneous injection. And in order to time the injection, we need to have an ultrasound, usually cycle day 11 to 12, unless advised differently by Dr. Lee. So when we do the ultrasound, what we're looking for is the size of the dominant follicle. The size of the dominant follicle correlates with whether it has a mature egg inside. And based on the size of the dominant follicle, the physician may say, go ahead and use your trigger injection now. What it does, it simulates that LH surge. It gives a boost of LH to mature the egg and ensure ovulation. It helps to define the fertile window a little bit more precisely than just relying on the LH surge. If you do go with the use of the Ovidrel, injection training is available through freedommedteach.com that shows you how to use the Ovidrel and how to do the subcutaneous injection. What else can you do to help yourself get pregnant? Well, please remember that this is a tandem event. It is not just about the woman or not just about the man. Both partners have a contribution to make to getting pregnant. There are modifiable lifestyle factors that you can work on. Stop smoking. This is a very big offender in increasing the time to pregnancy. Avoid excess caffeine, alcohol consumption, deal with stress, make sure you have some regular exercise, control your weight, and look at your diet. So another thing is chronic exposure to some environmental pollutants that you may ingest without even knowing that you are doing so. And they are DEHP and BPA. Those are two factors that are used to make some types of beverage containers found in a lot of plastic, dinnerware, toys, BPA epoxy resins are also used in the protective linings of food cans. So it is rather ubiquitous, meaning that it is widely, circulates widely in the products that we use that we may not even be aware of. And those are endocrine disruptors, which means that they can interfere with regular hormone levels and regulation of ovulation. Is there such thing as a fertility diet? Well, yes, there actually is. Studies have shown that Mediterranean diet has been associated with risk reduction of cardiovascular health and decreases the risk of diabetes, increased levels of folate and vitamin B that are necessary for embryo development and are also widely available through the diet. And overall, because of all the positive effects, it has a 40% increase in the possibility of pregnancy. That is all the information I wanted to share with you, but that doesn't mean that that's all the information that you need. Please remember that you can always send us your questions via patient portal. And now we have an opportunity to answer some questions. So one question is, in your practice, how often do you choose to have a woman try to naturally conceive with the help of supplements such as CoQ10, DHEA, vitamin D, etc., based on the most recent research and studies done with such supplements? So our doctors are definitely very plugged into the most recent research, and they will recommend supplements that they feel can help you conceive naturally. And those can include CoQ10, DHEA, vitamin D, myoinositol, and regular prenatal vitamins. So if you coming in, if you prefer to to try natural with just the supplements, we will definitely support you in that endeavor. So I wouldn't say that it's rarely or often or always. But more that that is an option that we will be happy to guide you through. Another question I see is, I'd like to learn more on how estrogen and progesterone can affect our ability to conceive, too little of it, too much of it, and what we can do to help those levels. So it's not a straightforward one part answer, but I'll try to do my best. Estrogen and progesterone levels do have an effect on our ability to conceive. Let me just go back really quickly to the slide. So as you can see, rising estrogen is both a reflection of a mature follicle, but it also will then rise during the luteal phase because it has a place in supporting the uterine lining. So estrogen levels could be affected by those BPA products, for example, that I mentioned. And so if we find that the estrogen levels are out of alignment, we could regulate them with the use of the medications. Progesterone progesterone definitely is a factor, because progesterone is so very important in preparing the uterine lining, not just to grow, but also change in its quality, in its content, to accept an embryo for implantation. That's why we can provide progesterone supplementation to be used in the cycle, whether it's a medicated cycle or a natural one. And it started usually after the LH surge or after the trigger injection, and at least until the pregnancy test. If the pregnancy test is positive, we continue further for up until 8 to 10 weeks of gestation. So the answer is yes, it's definitely a factor, and we do have tools we can use to help support those levels. Another question I see is, taking breaks during treatments hurts my overall chances? Absolutely not. Okay, I will qualify and clarify that. You do not have to be going cycle back to cycle, back to cycle, back to cycle. However, a lot depends on your age group as well. So if you are 34 years old, taking a month or 2 months or 3 months off and try naturally, or simply just taking a break from tracking your fertility window, will not have any negative impacts. If you're over 40, taking a month off between cycles, taking a break, and just doing nothing will not hurt your overall chances. However, over 40 years old, for example, we would not recommend taking a break longer than 1 or 2 months between tries. And if you've tried medicated cycle but didn't conceive right away, should you be worried? Absolutely not. Absolutely not. It is, as I mentioned, just to go back here to this slide, depending on your age, you only have a 5 to 20% chance per month of conceiving, whether medicated or natural. And the reasons for that is this narrow fertility window, as well as our own biology. Things have to line up perfectly in order for us to be able to get you pregnant in any given treatment month. And then I do have another question, and that is each person Fertility Cloud a separate business entity, or is everyone employed by Fertility Cloud? So I'm not sure if you were answered, but thank you for asking. We have both employees and contractors based on business needs and regulatory requirements, but we are we're very clear about everyone being highly qualified. Okay, and what is more effective, Clomid or letrozole? That is not an easy question to answer, because letrozole is the first choice of treatment for those with ovulatory dysfunction. However, some patients respond better to Clomid because these two medications, although the end result is that they increase the availability of your own natural follicle stimulating hormone that helps to recruit and grow the egg. However, the way they work, their mechanism is different. And for some patients, you need the Clomid, for some you need letrozole, and for others, you may need a combination therapy. And should you always use trigger shots with my medicated cycles? No, not necessarily. Trigger shots are an option. If you have regular cycles, or even if you don't, but letrozole or Clomid have regulated the growth of the follicle and achieve ovulation, you may not need the trigger shot. You can time the fertile window by the LH surge. Now, one thing is, although the actual fertility window is somewhat narrow, as I mentioned before, you should start having intercourse every other day starting on day 10, because sperm survive for longer than the egg, and you want the sperm waiting for the egg and not the other way around. So, even if you say have intercourse on day 10 and you ovulate on day 12, you will still have sperm waiting for the egg. Now, one other thing that I wanted to bring up, and that sometimes comes up, and that is frequency of ejaculation. You do not want to abstain for longer than 2 to 3 days prior to either insemination or attempting intercourse during fertile window. Holding on to sperm will not increase number of good sperm. In fact, it would increase number of dead or dying sperm. So the male partner does need to be having regular ejaculation every couple of days in order to have the freshest possible sample at the time of conception. What is more effective? Starting medicated cycles on second day 3, 4, or 5, no difference. There have not been any studies that have shown a difference in efficacy or how it increases your chances of conception depending on which day you start. So you can start on day 3, day 4, or day 5, and your chances are still going to be the same. Testing for pregnancy every single day after cycle day 24, no. And the reason for that is home pregnancy tests, even the most sensitive of them, will not pick up pregnancy hormone levels until those hormones levels reach a certain number. And in fact, you don't want to start testing until you are at least 13 days prior to the start of the pregnancy test. So you have to be at least 13 days after ovulation before you test for pregnancy. Otherwise, you are simply creating more anxiety for yourself and not likely to see a true result. If you are spotting for a few days prior to starting your cycle day 1, you still want to wait before starting medications until you get the first day full flow. and you still want to do a home pregnancy test to confirm that you're truly not pregnant, because spotting is actually common in about 25 to 30% of women throughout the first trimester. And should you consider progesterone supplementation, even if my PDG results have been positive? So as I mentioned before, PDG test only tests for the metabolites of your own progesterone. It does not reflect supplementation, and it doesn't truly reflect whether you have enough progesterone in the system to support the lining. So even if your PDG test is positive, you could still consider using progesterone to support the pregnancy. And then what happens if I miss the next cycle day 1 and report it only on cycle day 5 or 10? So if you report it on cycle day 5 and you have your medications, you could still start a cycle. If, however, you don't report it until cycle day 10, that unfortunately you will not be able to start medication, but you could still utilize your fertile window. You could still do intercourse every other day, and you could still consider progesterone supplementation. So you could still use that cycle, just without letrozole or plume. I am just checking to see. And it looks like we do have one other question. What is the most accurate ovulation prediction? If you're asking about what is the most accurate ovulation predictor test, our first choice is the proof kit. If you would like to explore other options, we can definitely recommend something or let you know what other options are. We also can provide you with a kit called KEGG, K-E-G-G. And that is a kit that helps to determine when your ovulation is coming or occurring by helping you test the cervical mucus. So it takes the guesswork out of trying to actually look at it and see, okay, I think it looks like egg whites, but I'm not sure. So KEGG actually helps you determine that without trying to guess. So if you've had, if you would like to get that confirmation, you can ask us for the KEGG kit, or use the proof along with a LH testing and a PDG confirmation test. And with this, I am going to finish